Welcome again to Edu-PIC. Today we're presenting our first talk from our ventilation course, Vent Online, for free on our channel. And we're starting with Principles of Mechanical Ventilation. I'm Ahmed Gamal Sharif, and here we go. So we're going to try to cover goals of ventilation, physics and mechanics of ventilation, concepts behind modes, misconceptions and myths around mechanical ventilation, important practical points, as well as adverse effects of ventilation. So let's start with just a glimpse of history. So as you can see, the first trials to deliver positive pressure ventilation started in the early 1900s. By the time we got to the 1930s and polio has been a pandemic, iron lung was developed and negative pressure ventilation has become more fashionable, as the thought was it's more physiological. CPAP as a concept has been more described and more developed in the 1980s, and in the 1990s people started thinking about non-invasive modes, especially with neuromuscular dystrophies and Duchenne's. As things progressed more and more in the early 2000s, pediatric specific non-invasive ventilation equipment, machineries and modes have been developed, and since then we've been playing with all the tools that we've got gradually and trying to figure out how to improve things more. This is iron lung if you've never seen it, and basically the child is put in there, or the patient is put in there, and the whole tube around the child sucks the chest wall out using negative pressure, allowing for chest expansion and aiding in breathing. And you can see the child smiling because this is an advertising picture. So what are the goals of ventilation? Why do we ventilate patients? Well, one sensible point would be preventing or improving respiratory failure, either type 1 or 2. If the work of breathing is very impressively there and the patient is really uncomfortable or having trouble keeping up, then this is to relieve the work of breathing. Sometimes we ventilate patients, especially little children, to facilitate procedures and use anesthetics. We can go for positive pressure ventilation to support the cardiac function. We can use it to facilitate neuroprotection when the patient is either in coma or if we induce the coma. Post-operative care sometimes demand a bit of more prolonged period of mechanical ventilation and sedation. Like if there was a child coming back from a laryngoplasty, as an example, where you need to keep the tube in for 4 or 5 days. Also to relieve the energy expenditure and multi-organ failures, like sometimes when we've got a patient who's in profound septic shock, who again can't keep up, or a patient in heart failure. So how do we normally breathe? How does breathing go normally? As you can see here, basically via the contraction of the diaphragm and the respiratory muscles, the lung have more room and expand, causing negative pressure, and that negative pressure sucks the air in. That air gets down all the way through the small airways in the lungs to the alveoli that are covered and surrounded by a capillary blood network that has got higher CO2 and lower oxygen. So with gradient, the oxygen goes into the bloodstream and the CO2 goes out, facilitating both oxygenation and ventilation. But what we do with positive pressure ventilation is facilitating the same process down in the alveoli, but with the opposite way, using forced pressure, pushing the air in through the airway. So basically, this is why we call it positive pressure ventilation, because you're pushing air in using positive pressure. And if you're doing that, if you imagine the airways down to the lungs simply at this figure, then if you're applying a higher amount of pressure or a positive pressure, then basically your aim is to deliver a flow down the airway, but that flow will always face resistance because that airway is a narrow tube and can be narrower down the way. Then basically that pressure that has facilitated the flow against the resistance will face another component of pressure that already remains in the lungs or the alveoli, which is what we call baseline pressure, or PEEP in our instance of ventilation. So basically you need higher pressure than the baseline pressure, and that higher pressure needs to be significant enough to facilitate delivering the air via a flow against that resistance and the baseline pressure. And if you play your cards right, you can expand these lungs or the alveoli or the balloon down the road. But there's one more component that you need to think of, is the distensibility of the lungs or that balloon there, which we call compliance. And the higher the compliance or the distensibility, the easier it is for you to cause that distension with less pressure. And according to this story, the airway pressure, or the pressure that you need, is basically calculated using this equation. So flow times resistance altogether plus volume divided by compliance altogether plus PEEP. And basically, as you see from this equation, to deliver basically the higher the resistance, the higher the pressure, and the less the compliance, the higher the pressure. And if you take the last bit of the equation, you get the alveolar pressure. All right. So back to physiology. So as you can see on this curve, this is the lung starting volume. This is the area where you're usually breathing normally, and where even if you're using positive pressure mechanical ventilation, if you're aiming to keep things around the target volume, then you're usually keeping things more physiologic and less harmful. But having said that, even if you're going on with your breathing, if you force yourself to have the biggest breath ever, then you're only going to maximally go all the way to your inspiratory capacity, and that's going to be it. You can't descend more. And if you force yourself to breathe out, you're still going to leave some air in your lungs, which we call the residual volume. And that's really important so that the lungs don't completely collapse. The whole area from the maximum point of breathing in, which is the inspiratory capacity, all the way to the end point of your expiratory reserve volume is called the vital capacity. And this is basically explaining how breathing normally goes, even if you're forcing things in or forcing things out, and giving more physiological importance of keeping some air in, which we facilitate with PEEP. Okay, using a similar module to the figure that we had before, so a straw and a balloon, and basically trying to explain how positive pressure ventilation works. As you can see at the beginning, the distensibility is a bit slow, and that balloon starts to distend really quickly afterwards. But why is it really slow at the beginning and really difficult, and then goes a bit easier afterwards? Basically, if you go with this curve, using this as your pressure axis and this as your volume axis, your starting point with every breath is going to start from where you've set your PEEP or kept your residual volume. And at that point, you start delivering some pressure. That pressure will generate volume. But because the lung might not be completely distended, then you're basically pushing against a bit of resistance, and you're still going with the whole pathway to get there. So you're causing alveolar recruitment and facing airway resistance till you get to what we call the lower inflection point. As soon as you get to the lower inflection point, where you're only facing the compliance of the lungs, you're supposed to generate more volume with every bit of pressure that you get in, till again you get to a point where you're only over descending the lung. You got to the maximum inspiratory capacity and you're just pushing further. Then you get some peaking on the curve, and which is basically telling you that with every pressure you're giving, there's less volume generated and there's no point of what you're doing, possibly just harm. As you release, you get back slowly to get to the upper inflection point, and then things go down really quickly with recoil. So what does that tell us? That tells us that at some points, if the compliance is less and that things are not going really well with lungs, or if the resistance here is high or whatever, then possibly you need a higher PEEP to overcome all of this and facilitate the breath being closer to the lower inflection point, so that you don't need a lot of pressure above the PEEP to go down that. I think this might explain it a bit more. So this was a study that had multiple CTs going down the way of recruitment, or basically going up with pressures, and see how that affects lungs. Needless to say, that's a lot of radiology dosing, but we're using it now to explain the points. So as you can see here, the lungs has limited air, if no air at all, and then with the beginning of the pressure, or with the increasing the pressure from 0 to 5, well, you barely got some air in, there's nothing much there. Then they kept going up to about 15 centimeter water of pressure, started having more air, then here 25, proper amount of air getting into the lungs, all the way to 35, where there's possibly decent amount of air, and then the lungs go back gradually. But as they go back gradually to a pressure of 5, possibly there's better air after the push that go all the way here in comparison to where they started. Okay, so going back to physics and some of the concepts of physics. As you can tell, obviously resistance and compliance would vary with lung volume and disease. So if the lung has got good residual volume, that would affect what you're doing, as what we've explained on the curves. And there are diseases that would increase the resistance or decrease the compliance, and vice versa. The rate at which a desired volume is achieved with a set pressure is defined by time. What does that mean? Basically, if you already set your volume to the total volume that you're aiming for, which is usually 6 milliliter per kilogram, and you want to achieve that volume with a set pressure as well, like let's say you've set the pressure to be around 20, then the only factor that remains here is time. How quick can you get that pressure to achieve that desired volume? And for that, we would have to visit the concept of the time constant. So one time constant equals the time required to inflate or deflate 63% of one lung unit. So to fill the whole lung, you're going to need more than one time constant, obviously. And to calculate it, basically the major players, or the main players in the whole concept of time constant, are the resistance and compliance. So as you can see, time constant equals resistance times compliance. So that if the resistance is high, you need more time, and if the compliance is high, you also need more time. So a disease with high resistance will require more time. A disease with low compliance will require less time. And that is important because RDS says a disease with low compliance. Asthma is a disease with high resistance. So just keep that in mind. Another concept that we need to talk about is the relation between gas exchange and interpulmonary shunting. What does that mean? So basically, let's go with normal. The air goes down the airway to the alveoli, and the alveoli have got venous blood going around in the capillary bed, gets oxygenated, goes back to arterial blood. In this case, ventilation in relation to perfusion would usually equate 0.8. We're not going to delve on how we got to this number, but just keep that in mind, right? So there's ventilation that is higher than perfusion, achieving a result of 0.8. But let's say that your airway is obstructed, the alveoli is completely collapsed, or like it's not basically getting any air to it, it's plugged, it's collapsed, it's unfunctional because of an airway problem. Then the blood is going there, it doesn't get any air, it doesn't get any air in front of it, and doesn't get any oxygen in front of it. So it goes back still unoxygenated. In this case, V, which is ventilation, divided by Q, which is perfusion, will equal 0. And in that case, this is what we call intrapulmonary shunting. Why is it shunting? Because it's what you would expect from a patient with congenital heart disease causing shunting of deoxygenated blood into oxygenated blood. You've got deoxygenated blood going back to the main bloodstream, and that would affect saturation of the blood, basically, and it's basically the same process or concept of shunting, but without a real shunt. On the other hand, if your air is delivered all the way down to the alveoli, but the blood is not going straight to the alveoli and not getting any perfusion to the alveoli, then this air full of oxygen will not go back carried to the main stream, which is basically considered as a dead space, because it's like basically having a bit of plastic that has got air in it. It's basically unused oxygen, doesn't go anywhere except for going back. In that case, V divided by Q would be infinite. So why is that important? That is important because it goes back again to the concept of de-recruited lung. So as you can see, if this is your if this axis is the shunt fraction, how much of shunt intrapulmonary shunting is happening, and this is your PEEP axis. So at a PEEP of 5 in a de-recruited lung, you possibly have higher shunting. As you recruit the lung with higher pressures, you get to an optimum point where the shunting is quite less, because now you've opened most of the airway, most of the alveoli, which means more oxygen is delivered through the bloodstream back. But as you also go all the way up to the harmful points of overdistension, then the shunting goes back worse. Why does that happen? Basically because as you distend the lung to overdistension, some of the alveoli would squeeze the bloodstream and squeeze the blood vessels, causing some dead space and causing also some perfusion mismatch. Another concept we're talking about is alveolar ventilation or minute volume, which defines your ventilation quality, or what you're doing with ventilation. Is it enough to achieve your targets or not? And that is basically equal to respiratory rate times tidal volume. So if you look here in your normal breathing around the tidal volume, so this is how you're ventilating. This is, with every shift of breathing in and out, you're basically getting CO2 out and modulating your ventilation. So you've got two factors here. How much of that tidal volume are you achieving, and how many times are you achieving it? And this is where this is coming from. So with every breath you're getting out CO2. So with every breath, from a number point of view, you're shifting more CO2 out. But also from a size of breath point of view, that is also affecting how much CO2 is getting shifted out, right? And as we get to this point, so enough physics, and let's talk about modes of ventilation. And when we get to modes of ventilation, then this becomes a bit dodgy. What does most of the modes mean, and what do they achieve? What do they target? Which one is best? Lots of questions, lots of confusion. Let's start with nomenclature. What do they mean? So nomenclature basically is a fact because it varies, and it varies for different reasons. It varies because of how companies name their modes to have some ownership of them, and also varies according to what they do. So what they do is actually would make a lot of sense. So let's start with what they do. So three defining parameters define how we name a mode and what does it do, and to understand what we're doing with that mode. These factors or parameters are control or limit, trigger, and cycle. What do they mean? So control is basically finding what are you aiming for with your ventilation. Are you aiming to achieve a desired volume, or are you aiming to achieve a desired pressure? Like, are you targeting the pressure itself, or are you targeting the volume itself? And because of that, we've got volume controlled modes and pressure controlled modes. And this is the main defining point for most of our ventilation modes nomenclature. Then you've got trigger. So either each breath is triggered by time or triggered by the patient. So if it's triggered by time, you basically set a specific rate, and either you set the inspiratory time itself or the IE ratio, and through this calculation, having two factors, the ventilation is timed. Or you keep it to be more of a spontaneous mode, where the patient is the one doing the triggering, and hence we've got spontaneous modes and or synchronized modes accordingly. And that trigger comes either via pressure or flow, and that is also something that you can set. So if the patient generates that defined amount of negative pressure, you start a breath. Or if the patient triggers generating that amount of flow, then you facilitate a breath, and that's why you're telling the machine. And then you've got cycle. Cycle again can be time cycled or patient cycled. So time cycled again is basic cycle is how the breath ends. Does the breath end by a defined time, which is again set by the inspiratory time or the IE ratio and the set rate, or does it end by the patient generating pressure or flow to end the cycle? Okay, so again, control is what you're targeting, trigger is what starts the breath, cycle is what ends the breath. Then with time we got more complex with dual modes. So we've got now modes that would have both targets aimed for. So pressure controlled, volume guaranteed, volume controlled, pressure limited, and something like PRVC are good examples. So let's just take it a bit down. So pressure controlled means that you're actually aiming for a pressure. What does that volume guaranteed mean? It means that I'm aiming for a pressure, I've set a pressure, but I need the ventilator to guarantee that it's going to achieve a set volume with every breath. And basically in that case, you're still going with a pressure controlled mode, but you also are aiming for a desired volume, which makes things a bit complex. Volume controlled, pressure limited is possibly is not far off. So you've got desired volume, which is what you're targeting, but you set a maximum pressure, so you don't want to exceed that pressure. So it's still a volume controlled mode, but with a maximum pressure point, where the ventilation process would stop if you go above that pressure, and the breath would be held at that point till the cycling happens either by time or the patient. And then pressure regulated, volume controlled, or PRVC is another story. So the main point here is you just need to know at some point, what you will know with the rest of the Vent Online course when you attend it, that what you need out of all of this is to look at the ventilator waveforms and curves to identify what's your mode, what kind of control are you really using on the mode. Is it pressure or is it volume? Okay, and this table is showing you how complex nomenclature is. So it's actually better to understand what does the mode do rather than keep yourself confused about nomenclature. Because as you can see, different companies name same modes in different ways. Like a good example here, like let's have a look here. So if you take assisted control on this company, it's called VAC here, volume controlled here, CMV here, and just it's completely different. If you go to something like PRVC, it's called volume control plus PRVC, APV, and then VCAC or PCAC. And this, you can't rely really on nomenclature according to companies. It just becomes really confusing. Let's talk about misconceptions and myths around ventilation. There are starting settings for ventilators. Well, not really a rigid fact. And yes, there might be guidance in different units, might be guidance in some textbooks about starting settings, but actually starting settings should be always individualized to the patient's pathology and what you want to achieve. And where is your starting point from patient status? Like what's the blood gas telling you? What's the oxygenation status? Are you aiming oxygenating, or are you aiming ventilation, or are you aiming neuroprotection, or what are you aiming for? So having rigid starting points is not really a good concept to stick to. Pressure modes are better in pediatrics. Well, that generally comes from the fact that we're just good at using them, because most of us started learning ventilation through neonatal ventilation, which usually is taught using pressure modes. So historically that has been going on, where pediatricians were taught mainly pressure modes, and neonatologists specifically used more and more of pressure modes. But is it a fact that they are better in pediatrics? I would argue to differ, because there are different events, different occasions, different pathologies where possibly sometimes volume control would be actually far better, and it's still in the pediatric cohort. My point here again is it varies and should be individualized to patients and comfort of the operator and the unit, and how they're comfortable with this mode or that mode. When SATs are low, increase the FiO2 and weight. As we've explained more and more in this talk, you can get more oxygen and better oxygenation if you actually recruit the lung and improve the lung, because you're facing interpulmonary shunting in most diseases. And I'm talking about lung diseases, and you need to face that and fix that to improve the oxygenation. If you just get the FiO2 up and wait, this is not going to really get you anywhere, mostly going to get you some harm. Mode XYZ is the best ventilation mode. Again, it depends on, I think that comes from people's comfort in certain modes that they got taught and they used more often, but there is basically a simple rule around modes, which is basically the best mode is the mode that your unit understands the best. So you can hand over easily, people can change things dynamically, easily, and understand each other when they're handing over. But there is not a certain mode that is the best ventilation mode. High PEEP generally is dangerous. Well, high PEEP can be dangerous, but it depends on what you define high PEEP with. I've been to units where they're really anxious if they get the PEEP above 8 or above a certain number, and that is not, as we've explained again, is not the right concept. It depends on what you have to do to inflate the lungs properly and recruit the lungs and get a good starting point for your pressure or your delta P, or the generated pressure with every breath, to facilitate delivering a certain flow to distend the lungs and get it to the right point. So it's not a general statement to say high PEEP is dangerous. So just some practical points to make your life easier with ventilation, and it's gonna really affect what you do. Just try to remember that a big part of resistance rely on the diameter of the diameter and the length of the ET tube and the ventilator circuit. Going back to physics from school, you still remember that resistance is affected by length divided by area. So if the diameter of the cylinder is doubled, the cross-sectional area increases by a factor of 4, which makes diameter more effective than length. So if you're struggling with the amount of pressure that you need to deliver your ventilation, or you're facing higher resistance, then basically think about a bigger sized or bigger diameter tube. And that is really in practice. Having said that, we recommend using a cuffed ET tube whenever possible to minimize ET tube change with leaks and to be able to assess airway prior to extubation. Also, it helps if you're facing a disease that requires high pressure, so that the cuff can keep the air in and keeps the recruitment optimized. The caveat here is if that's going to affect your diameter to a point that would increase the resistance. And that's why most neonates end up getting uncuffed tubes. But just think about it whenever possible. Use a ventilator mode that you and your unit are familiar with, as I said before. Check the alarm limits, because some of the problems that happen with ventilation happen because you haven't set the alarm limits. Remember that ventilation is a dynamic process. You don't keep a patient on set settings and just forget about them for like 12 hours or 24 hours and not follow up on what's happening on the curves, on the loops, and on the blood gases and numbers that you can monitor on the patient. And also remember that lung physio is a strong ally in most cases. And when something goes wrong acutely, remember DOPE. So, is the tube displaced or disconnected, or the circuit disconnected, or there's any disconnection around? Is the tube obstructed? Is there pneumothorax or a lung pathology? Or if there's any equipment failure that causing these problems to arise. Also remember that tidal volume improves with increase in delta P as well as inspiratory time, which are the area under the curve, and that would improve both your oxygenation and your ventilation. If you're struggling to clear CO2, think about optimizing dead space, because it affects the real tidal volume. So dead space can happen on different levels. It can happen through tubing, can happen if you're not putting into account the area, the length of the trachea that basically sees your flow. So if the tube is a bit in a good place, then you're seeing less trachea. If the tube is high, then there's a longer way, although this is of limited effect really. And then there's the more important alveolar dead space that we've explained before, where there's no blood flow going to a certain part of the lungs. So the thing that you can really play with is your equipment dead space. Let's conclude with reminding ourselves that ventilation doesn't come without cost, and there are adverse effects to post-pressure ventilation, including ventilator-induced lung injury that can happen through oxygen toxicity, barotrauma, volutrauma, or atelectrotrauma. There also is the possibility of causing ventilator-associated pneumonia, or VAP. Post-pressure ventilation can cause cardiovascular instability in some patients. Examples would be decreased venous return with high intrathoracic pressures, or increased RV afterload and pulmonary vascular pressures by having increased, again, intrathoracic pressures. And that can be significant to patients with RV failure. Dysynchrony, if the patient and the ventilator are not really going in synchrony and harmony, which can cause prolonged sedation and delirium as a consequence. Thank you very much. So this has been the first talk of the Vent Online course that we're offering now on the channel for free. Stay tuned and follow us to follow up when we're doing the Vent Online course again at any point. Thank you, and I hope that has been useful.